Hey guys, hope I'm audible and visible. So welcome back again. So we had just had a recent discussion about study with me, where we discussed about RBC disorders. So here we are going to go with PYQ marathons, right? So we'll have a very quick look about many questions here. We'll have a look about 50 questions which came in the recent FMG exams. So if you're going to given this FMG exam, this might be very useful for you. I want active participation here. They are going to be easy. It's completely fine to make mistakes here. Do make a mistake here so that you will definitely not repeat the mistake in your real exam. Fine. And if you are using the Unacademy app, these are all the free tests for you which you can write, which you can attempt and which you can experience. Dining Shastri. Hello. Fine. The NEET PG 2022 batch coming up. If you want an extra push for your preparation, you can enroll to it. You can use any code if you want. If you don't have a code, you can use Pathocups. Fine. Okay. So let's go ahead. I do want answers from you. Active participation is like must, right? 50 questions. Maybe it'll take 50 plus minutes, maybe 10 or 20 minutes extra, and then we'll wrap it up, right? We'll see every question. After question, the answer you're going to answer it. Maybe some few points related to that I'll ask. Again, you're going to answer that. It's like a very quick brush up of almost all topics required for us for the entire pathology, right? So let's start. Read the question. Maybe after 10 seconds, start writing tell the answer. I hope the question is visible to you. This is an older question. The same question came in your NEET PG exam as well. What's the diagnosis? You should not take much time for this. It's perfect, right? Great. SS and Shastri has told answer C. Anyone? Great. Adi has gone with asbestosis, right? So it's a very simple one. You have a question of lung fibrosis with pleural thickening. See, I don't even want to know the image. Good Santosh. I don't even require the image here. It's pleural thickening. Do you know any other occupational lung disease which will cause pleural thickening? Yes or no? Nothing will cause pleural thickening, right? Only one thing which can cause pleural thickening is asbestosis. That's all. So I'm going to look for asbestos. Coal will not cause pleural thickening. Silicosis will not cause pleural thickening. Cotton fiber will not cause pleural thickening. The only one which is going to cause pleural thickening is asbestos. That's enough for me. Now I look at the image like Shashi said that I can see the structure here, right? You can see this brown color one. All these are asbestos bodies. There are multiple of them. These are called as an asbestos body, right? Asbestos body, since it's brown color, it's made of iron particles as well. So we have the term ferruginous bodies, right? So yeah, asbestos bodies or ferruginous bodies, that is diagnostic of an asbestosis, right? So we'll have few questions regarding pneumoconiosis. I'm going to ask you a question. You're going to comment the answer. Pneumoconiosis is due to inhalation of the particles. We already know that. Which particle size is called as a danger size for pneumoconiosis? Is it less than 5 micron, less than 1 micron, or more than 10 microns? Which is the danger size particles? Less than 1 micron, 1 to 5 micron, or more than 10 microns? The danger size particles are 1 to 5 micron size, right? These are the danger particles. Whatever gets stuck in the 1 to 5 micron goes into the lung and they will cause all the damages, right? Next question regarding pneumoconiosis. Perfect, Santosh. Fine. Okay. There is a slight discrepancy regarding this value between PSM and your pathology. So I don't know what to go with. This is what your Robin says. I'm going to go with that finding. Fine. Okay. So next question is coal workers pneumoconiosis. Will it cause lung cancer? Yes or no? Coal workers pneumoconiosis, will it cause lung cancer? Answer to that is no, right? They don't increase the risk of lung cancer. Silicosis, yes. Asbestosis, yes. But coal workers pneumoconiosis will not cause lung cancer, fine? Next question. What's the most common occupational lung disease or most common pneumoconiosis? The most common pneumoconiosis is silicosis, right? The most common pneumoconiosis is silicosis, fine? We have fourth option here, cotton fibers. What do you think is the disease termed as? For cotton fibers, we have a name of disease like cotton fibers is due to bicynosis, right? So bicynosis is related to cotton fibers. Fine, great. So what lung disease will be linked with your sugarcane? I think Santosh has gone a bit earlier and answered that, right? Bagasosis for sugarcane and bicynosis for cotton fibers, right? So we know a little bit in relation to that question. This is what we're going to do the entire session. We'll have something related to that question so that we can, it's completely fine, Santosh. We make mistakes here. we don't make mistakes in the main exam. That's the ultimate goal of answering all the questions, fine? We go to the next question. Again, this was an old repeat which came back in the recent INACT exam as well, fine? Right. Read the question and give the answer. I hope all the options are visible. We're going to do the same thing. Every question maybe 2-3 minutes max. Okay, great. This came in recent INACT and this is an old FMGE repeat, right? They don't change questions at all. Few of them, it comes the exact way. The question, I have multiple clues here. 5-year-old kid with proptosis. Most likely an embryonic tumor. PNET can also happen, which can also cause proptosis, fine. Lymphoma can also happen, which can also cause proptosis. Leukemia, by history, it's not going to happen in the proptosis. It will not go happen in the soft tissue. It will happen in the blood only. So other 3 possibilities are there with my first history of proptosis. Round cell tumor, lymphoma is round, PNET is round, embryonal rhabdomyosarcoma, all 3 are round cell tumors only. The only clue for me here is correct. Exani has said that it's Desmin. Desmin positivity, PNET will not be Desmin positive. I'm going to go for an embryonal rhabdomyosarcoma. Right? Embryonal rhabdomyosarcoma has to be a Desmin positive lesion. Fine. So I'm going to give you few IHCs, immunohistochemistry. You're going to tell me whatever lesion comes to your mind first. Any lesion from head to foot. Fine. We'll go have a very fast, quick outlook of all the IHCs. GFAP. GFAP is seen as glial fibrillary acid protein. It's a finding seen in CNS tumors, astrocytomas, gliomas, right? Synaptophysin. Synaptophysin chromogranin. Synaptophysin and chromogranin is a marker for neuroendocrine differentiation. Can be your carcinoid, can be your small cell carcinoma, any neuroendocrine differentiation, synaptophysin chromogranin. S100. Where do you see S100? And I'll give you maybe 2 seconds. I want you to comment. Make a mistake here, it's completely fine. S100. Remember like this, S100 is a marker for neural crust origin, right? Perfect, Vishal. One thing for me is melanoma. Melanocytes is neural crust, right? One thing for me is melanoma. Can I say that Schwann cells origin is from neural crust? Neuroectodermal neural crust origin? Yes. Schwannoma as well. Fine. That's also neural crust origin, right? Langerhans cells, again, yeah, they also come from the neural crust origin, right? Sustentacular cells. There are many things, but I'm going to use it for diagnosis. Langerhans cells, since Adi took us to a different pace, I'm going to ask you what is the perfect marker for LCH? For LCH, what is the best marker? S100 is a decent marker. I won't say it's the best marker. What's the best marker for LCH? It's got to be CD1A or Langerhans. Say I would prefer CD1A because Langerhans is a marker which might not be available in many places. CD1A is a good marker which will be available in many places. That's a marker for a Langerhans cell histiocytosis. Fine. Next, we'll go with napsin A. Where do we use napsin A? I think Vishal, it must be 1A, mistyped as 19, right? It's completely fine. Where do you see napsin A? Again, I'll give you a few seconds. I want you to comment. Napsin A is a marker which is useful in the diagnosis of lung adenocarcinoma, right? Lung primary adenocarcinoma, napsin A is useful. I use them for one more tumor as well in the ovary, which came in the recent INACT, clear cell carcinomas, right? So clear cell carcinomas of ovary also will have napsin A positivity. Napsin A is for 2 things: lung adenocarcinoma, perfect, and also your clear cell carcinoma of ovary, right? You go to the next image, next question. Okay, again, I want you guys to comment faster. You may be wrong, you may be right, doesn't matter at all. Read the question and comment. 30 seconds timer for you. Perfect. I have various answers here. Okay, most of you went for C or option 3, right? Few of you for A and B, right? We'll have a look at this. See, first, there's a following injury, a lesion from the 4th day after the injury, which is the type of collagen, right? So when will you have a scar formation? A scar formation will take at least a week, right? Perfect, right? It'll take at least a week. After a week only I'll have scar evaporation. So means around 4th day, what will be the wound change? I'm having an wound around 4th day, what change will be there? That's my first MCQ. If I know that, my answer is very, very simple. Around 4th day, what I'll have is granulation tissue. See, I'm having granulation tissue. When you look at the image, day 5 or day 4, I'll have granulation tissue, right? So when you look at the image also, can I say that all these tiny, tiny ones are capillaries? I do have lots of capillaries here. Capillary rich tissue is a granulation tissue, which means it also will have collagen. Now my answer becomes very easy. I have to rephrase the question as, what is the type of collagen seen in granulation tissue? Granulation tissue type of collagen, I'm sure you know that. It is your, I'll zoom out. It has to be your type 3 collagen, right? But which tissue you will have type 1 collagen? Few of you answered option A. Type 1 collagen will be seen in a mature scar tissue. It will be seen in a scar tissue. I want you to remember this forever, because I can easily twist this question and ask. See, it's a very basic fact. So if it's a fact, if I say that a patient has liver cirrhosis, cirrhosis is nothing but scar tissue, right? What type of collagen you will see? Type 1 or type 3? We'll see type 1 collagen. Myelofibrosis, type 1 collagen. Any lung fibrosis, type 1 collagen. Type 1 collagen is going to be seen in any scar tissue from head to foot. It's information which I can use from head to foot all over, right? Great Tawfiq, great Sashi. Okay. So here, let's have a quick look about few more MCQs quickly. Special stains. We'll go with a little bit difficult special stains. The stain for collagen. What is the stain useful for collagen? Stain useful for collagen. Mason's trichrome. I'm writing empty. Stain useful for elastic tissue. Again, few seconds. I want you to comment. Elastic tissue. Verhoef Van Giesen, right? Stain useful for, let's say, H. pylori. I'm just asking random stains. Nothing is linked with each other. What is the stain we use for H. pylori? For H. pylori, we have Giemsa stain. That's a stain useful for H. pylori. And also we have one more thing called as Steiner silver. Okay. The stain Warthin-Starry is a good thing. See, Warthin-Starry, if you are specifying Warthin-Starry, I would prefer you to answer that for your syphilis. Fine. It's the Steiner silver, which is a modification which is done for H. pylori. I can use Warthin-Starry also if I don't have Steiner silver in the option, right? Steiner silver is a better one than Warthin-Starry, fine. Okay, one more stain for acid mucin. I am not just asking any random mucin. I am asking specifically acid mucin. It is expensive. For acid mucin, what is the stain? This came in an MCQ as well. It is Alcian blue, right? Perfect, great, right? PAS is for neutral mucin. For acid mucin is Alcian blue. That came once in an AIMS exam, so it's an Alcian blue positive for acid mucin, right? Great. Okay, so you know few things in relation to that. Okay, I'll go to the next image question. I want you to comment on the answer, then we'll go and look at the answer. It's fine if you're wrong, but I want you to comment on the answer. Great. So here it's in thyroid adequacy for thyroid FNAC. See, there are many things which is almost every biopsy and FNAC has a qualifying criteria. For example, I need to see at least 5 bone marrow spaces for an adequate bone marrow biopsy. For thyroid FNAC, I need to have at least 6 follicles, and each follicle should have 10 cells. So how will it look in my microscopy is this. See, this is a follicle, right? This is how an FNAC of thyroid will look. If you look at the FNAC of thyroid, this is a follicle, this is a follicle, this is a follicle. Are you seeing 10 cells in every follicle? Right? This may be a group of follicles, right? So when I see them, I can easily call them adequate, because I need some adequacy, some basic criteria to say negative reporting, right? Because if I see only one follicle and I have missed a follicular custom of thyroid, or in papillary carcinoma of thyroid, it might be a bit difficult for me to go and justify it on a later date, right? You have 10 cells and I should have at least 6 follicles, right? That's adequacy. Okay. And how an FNAC is done, right? If you have an image of, because you have multiple images coming up in your exam, this is called as an FNAC gun. You can see the person using a metal gun, right? In the metal gun, you will hold the FNAC needle, you will poke it, and if you can have a look, this is suction apparatus. I can pull it, it'll give me a negative pressure. Based on the negative pressure, and I push in and out. When I push in and out, that will dislodge the cells. With the negative pressure, I'll aspirate the cells that is made on a smear. Okay. So when I do an FNAC, I generally do 2 stains. One is PAP, other one is JIMSA. Okay. There are 2 stains done for all FNACs, right? Sorry. Okay. So I'm going to ask you a few more questions regarding that. I'm having a stain of pap smear, right? What do you think is a fixative for pap smear? Because this is again a question related to fixative, which also has come in the previous years. What's a fixative for pap smear? Pap smear fixative? It is alcohol. It's alcohol's fixed. Pap smear should always be fixed with alcohol, be it the pap smear in the cervical lesion or be it in your FNAC. Anything? Yeah, ethanol 95%, absolute alcohol, that should be there. JIMSA, what do you think is the fixative? JIMSA fixative? JIMSA? JIMSA smears are air dried. Okay, they are air dried smears. I don't have any fixative for that. I just dry them and I start staining them, right? The staining will have the fixative in that. I don't fix specifically. Pap smear is for alcohol and JIMSA are air dried smears, fine? So this is a little bit about my FNAC, fine? The only lesion where FNAC should be done is your thyroid. In a real life, I don't want any one of you in future to do FNAC for breast or any other organ. Thyroid, yes, it is mandatory because I cannot do a biopsy. For other organs, please prefer a biopsy because FNAC has its own disadvantages. Which organ I cannot do FNAC? Which organ FNAC is contraindicated? One organ, when I have a cancer, FNAC is contraindicated. Which organ is that? I'm sure you know that. The organ is? It's fine if you're wrong, completely fine. Testis. Right? For CA thyroid, I can use it. For testis, I cannot use it. Okay. Thyroid FNAC is the way to diagnose, right? For testis, I can't do it. Liver, if I want, I can do it. For testicular neoplasms, FNAC is contraindicated. I'm sure you'll know that as well. Why FNAC should be why FNAC is contraindicated in testis neoplasm? I can do FNAC in a kid. We'll sedate the patient and do it. Why it is contraindicated? Because it will spread. It will spread. That's the reason FNAC is contraindicated. It's not the main reason is the spread. It will change the direction of spread. Okay, that's more important. It changes the direction of spread. That's more important. I'll tell Sojanya just a minute. Fine. When I do an FNAC of thyroid, that also will spread to the lymph node, right? The direction of spread changes. What is the draining lymph node for testis? Testis is an intra-abdominal organ. The draining lymph node is your abdominal lymph node. But when I do an FNAC, the needle goes via scrotum. When it comes to the scrotum, it goes to my inguinal lymph node. Cabana is for penile, right? For the FNAC of testis, it generally goes to paralytic lymph node. I am going to change the direction of spread. After FNAC, I am going to change to inguinal lymph node. So I am definitely worried about that, right? I change the direction of spread, so I am going to not do a testicular FNAC, fine? So coming back to the question of Saujanya, what are the disadvantages of FNAC? I don't have a tissue here. These are only cells. When I don't have a tissue, can I demonstrate invasion? Possible, not possible on an FNAC? I can't demonstrate invasion. So I have to suspect invasion. I don't see invasion on microscopy. So I don't prefer FNAC. That's one. Second, most of the cancers are diagnosed based on immunohistochemistry. Like you said, Desmin, positive, I know it's rhabdomyosarcoma. Can I do immunohistochemistry here? Marker studies are not so perfect on an FNAC. So I prefer biopsy, fine? The main two disadvantages, I cannot look at the invasion, then I cannot do markers. No IHC can be done, so I prefer an biopsy over an FNAC. Fine. Okay, we'll go to the next question. Okay, look at the thing and comment on that. Okay, great. I want everyone watching the video to comment. It's completely fine if you make a mistake. See, there's a vacuotinus, right? So vacuotinus are based on the color of the cap. A red color will have clot activator. We have other 4 options. We look at what will be the color for other 4 options, right? And sodium citrate, what color do you think will have? Citrate will have, perfect. Citrate will have a light blue color vacuotinus, fine. EDTA, purple, right? Purple or a lavender, whatever you want to call. Purple is going to be an EDTA. Perfect. Heparin, you will have green color vacuotinus, fine. So we know the color of vacuotinus. The reason why I'm making it color coded is because for each of the diagnose, each of the test I want to do, I have different application. That's all. A red color vacuotinus, what test you will use it for? This vacuotinus is useful for what test? Red color vacuotinus is useful for one particular test. It's useful for all serological assays, right? These are useful for all serological assays. Any serology, I'm going to use in red color vacuotinus. Where do you use your sodium citrate? CBC is not done in red color vacuotinus. It's for any serology because it will clot. I can use only the serum profile. For any serology, I use that. Fine. Sodium citrate, where do you use? Sodium citrate is useful for all your coagulation profile, PT, APTT. You should not do PT, APTT in any other thing other than sodium citrate. Fine. Where do you use EDTA? EDTA is the commonest one. This is where I use CBC. CBC peripheral smear is done for an EDTA, right? Heparin, I want you to remember one thing for sure. I'm sure if you have worked in an internship, you must have done it. For which test we require heparinized sample? We require heparinized sample for only one test. What test is that? Heparin. Heparin. I want every doctor to remember that only one sample requires heparinization for always, which is ABG analysis. You cannot do ABG analysis on any other breed. It should be done only on a heparinized sample, right? Because ABG analysis is a very, very important critical determinant for your ICU patients. Your ABG analysis should be done on heparin only. And also we have one more test called an osmotic fragility test, which we use it for hemolytic anemia. That also is done on heparin, right? I purposefully ignored ESR in spite of many people saying that. I want the test itself to be removed, right? I don't want ESR. I want the test itself to be removed because it's a very useless test. We'll talk about ESR sometime later, right? Okay. Next. I hope you are able to see the question. Look at the question and comment on that. After that, we'll see something related to that question. Everyone has to comment. It's completely fine if you're wrong. Okay, great. So I have different opinion here. Predominant of you went for A. Some of you went for C, right? Very few of you went for C. I want people who answered C. Why did you go for C? Is that because of the non-necrotizing granuloma? Right? So when you look at this, I'm sure you must have picked up it's a granuloma here, and this granuloma is not having necrosis. So this is a non-caseating or non-necrotizing granuloma. Fine. Non-necrotizing granuloma, you must have preferred sarcoidosis, so you went for sarcoidosis. Completely fine, right? Keep this in mind always. When you have a granuloma or a giant cell in an image, unless proved otherwise, that is only tuberculosis, right? Almost always tuberculosis. If whether it's necrotizing or non-necrotizing, it is tuberculosis only. See, when you wrote sarcoidosis, look at the history. Fever and cough for 15 days. Do you think sarcoidosis will present as fever and a cough? It can trending videos. Okay. See, trending videos, it's a cervical lymphadenopathy. When you have a sore throat, can you have cervical lymphadenopathy? You can, right? So it's possible to have it. Maybe it is a low-lying thing which got reactivated, which can happen, right? So cervical lymphadenopathy, when I'm having non-necrotizing granuloma, anywhere non-necrotizing granuloma, my first possibility is tuberculosis. Sarcoidosis is always diagnosis of exclusion. Whenever you see granuloma from head to foot, I am going to go for tuberculosis early, yes? So history supports TB, that's important. Like Shastri said that for me to diagnose something as sarcoid, it has to have very classical findings. It should involve lung, most likely bilateral. It should involve hilar node, again most likely bilateral. It should have elevated ACE enzymes. It's a clinico-radiological and biochemistry finding, right? And they should have hypercalcemia. Okay. Then in microscopy, I should have non-necrotizing granuloma. See, when you have all these findings put together, I can say that yes, sarcoidosis is a better bet there. Otherwise, I'm going to prefer tuberculosis only. Keep in mind, always prefer tuberculosis. If all these are there, I can prefer a sarcoidosis, correct? Otherwise, not sarcoidosis, fine. Okay. Next image, look at the question and then comment on it. Okay, I'll give you a few minutes. I want everyone to comment here. It's completely fine if you're wrong. We'll learn from this. Great. So predominant of you has gone for option C, right? Let's look at the question and see whether we are correct or not. A 45-year-old person who is a chronic smoker came to the clinic with complaints of cough. Physical examination was done and biopsy is taken. The below is the description of the biopsy, right? So when you look at this side of the biopsy, what epithelium you are seeing here? All of you are correct here, right? What epithelium are you seeing in the marked area? Can you see the cilia? The tiny cilia? This is my pseudostratified ciliated columnar epithelium, right? This is normal. This is normal in my bronchus, right? When you look at the other one, the way to identify it has changed is, look at them. It's single layered or multiple layered? It is undoubtedly multiple layer, right? When it's multiple layer, it has to be stratified. The only epithelium which happens in the oral cavity, bronchial lesion, which can be stratified is my squamous epithelium. It's stratified squamous epithelium. So it has gone in metaplastic change, right? So it's a metaplasia. To be specific, like some of you said, it's in squamous metaplasia. This epithelium has changed to my squamous epithelium, so it's in metaplasia. So few questions in relation to metaplasia. Is metaplasia reversible? That's my first question. Is metaplasia reversible or not? I'll come to your question training videos. Is metaplasia reversible or not? Metaplasia is reversible, undoubtedly. Next question. Is dysplasia reversible? Is dysplasia reversible? When I take dysplasia, I need low grade or high grade. A low grade dysplasia is still reversible, right? High grade dysplasia is irreversible. High grade dysplasia in the sense like CAN3. CAN3, the fourth option is a dysplasia. CAN3 is irreversible, right? Can I say that CAN1 is reversible? CAN1, that's also dysplasia. It is reversible for sure, right? A low grade dysplasia is still reversible, and it becomes a high grade dysplasia, it is irreversible, fine. Okay, coming back to your question trending videos, you told that can I call it an intestinal metaplasia instead of this? See, I cannot call this as intestinal metaplasia, but when you have a patient with Barrett's esophagus, what metaplasia do you think will happen? In Barrett's esophagus, the normal lining of esophagus is my squamous epithelium. Squamous epithelium changes to columnar epithelium in Barrett's. Will columnar epithelium have goblet cells? They will have. So can I call that an intestinal metaplasia? I can call it, right? I cannot call this intestinal metaplasia. In Barrett's, I can call it, right? We have kind of ruled out removing the word intestinal metaplasia. It's an older term, but if it comes in a question, it's for that, not here, fine? Few more metaplasias. Do you know any metaplasia which happens in the mesenchymal tissue? See, this is an epithelial metaplasia. Your squamous in the smoking and Barrett's is epithelial metaplasia. You know any mesenchymal metaplasia? Any example for mesenchymal metaplasia? A gist is a tumor, Ranjith. It's not a metaplasia. Any mesenchymal metaplasia? Perfect. Myositis ossificans. See, gist is a gastrointestinal stromal tumor. It's not metaplasia, it's a tumor. Myositis ossificans is a metaplasia, right? When the bone breaks, I can have bone formation in my muscle or in the soft tissue or in the ligaments. That's a mesenchymal metaplasia, right? Perfect. Can I say metaplasias can progress to a cancer? Yes or no? True or false? Can metaplasia become cancerous? Yes, they can turn into a cancer, right? Metaplasia can turn into a cancer. Not all metaplasia. Myositis ossificans cannot form cancer, but squamous metaplasia can. Barrett's esophagus can, right? Okay, I'll go to the next question. Read the question carefully, and I hope you're able to see all the options. I'll give you a few seconds to comment, but I want all of you listening to this video to comment on the answer. So it's a clinical scenario. Based on that, I have a few options. First, I need to identify the diagnosis. Then I should know the options. Cool. Okay, first tell me the diagnosis. Again, I want everyone to participate. It's completely fine if you're wrong. My diagnosis here is minimal change disease or lipoid nephrosis. Both mean the same, right? 4-year-old kid having an edema, 2+ or 3+ proteinuria, and responding to steroids. All of them are classical clues for me to diagnose to win minimal change disease. So when I say minimal change disease, it's a nephritic syndrome or nephrotic syndrome. Nephritic or nephrotic? It is a nephrotic syndrome. Perfect. So it's a nephrotic syndrome. It will not have RBC cast. Eosinophils no, amyloid cast no. The only thing which a nephrotic syndrome will have is a lipid droplets or a lipid based cast I can have because of nephrotic syndrome. Perfect. So look at the other options. Where do you think I will have red blood cell cast? A red blood cell cast, where will you see them? Nephrotic or nephritic? Yeah, Abid, I have pushed a little bit so that I can orient it. Next time I'll change the image, fine. It'll be seen in nephritic syndrome, PSGN, any nephritic syndrome, I'll see red blood cell cast, fine. Okay. Eosinophils in urine, diagnosis. Eosinophils in urine, diagnosis. That's a very classical diagnosis. I see eosinophils in urine. Think of an drug-induced interstitial nephritis. Okay. When you have eosinophils in urine, drug-induced interstitial nephritis is one of the possibilities. Parasitic infection is a bit rare. Most likely allergy. That's due to drug, hypersensitive reaction. A drug-induced interstitial nephritis will have eosinophils in urine. Amyloid you will see in multiple myeloma or any amyloid related problems, fine. So I have few urine microscopic image. I want you to look at the image and comment what comes to your mind first. What is this? All these are urine microscopic images. Comment on whatever comes to your mind first. can comment anything, whatever comes to your mind. What are these cells? These are all RBCs. Fine. Urine microscopy is not stained. They are not stained one, so I have RBCs here, right? They're just RBCs, right? All these are RBCs. Since they are not stained, it looks like a ghost cell. That's all fine. So this finding, can I call this also as an RBC? Is this also an RBC? Yes, both of them are RBC, right? This is also an RBC. So I'll zoom out once, fine. When I zoom out this, I have two images for RBCs. What do you think is the difference between them? This is normal RBCs. I am not calling it cystiocyte, Vishal and Shrishti. I'm going to call them an dysmorphic RBC. I can call it dysmorphic RBC, right? It's not normal. It is a bit ugly looking, right? So on the top, I have almost decent RBCs. The bottom one, the shape is a bit abnormal, dysmorphic RBC. When I see dysmorphic RBC, it is very, very characteristic for me. What do you think is the source of bleeding? The urethra or the kidney? That also came in an exam once. Urethra or the kidney? Dysmorphic RBCs, the source of bleeding is most likely from my kidney, right? Which means indirectly I'm saying glomerulonephritis, right? If the bleeding happens from the kidney, it has to go through the proximal distal convoluted tubule. Your ureter, bladder, urethra come outside. By the time it have got damage. Nephritic syndrome, glomerulonephritis, dysmorphic RBCs. Fine? Okay. Next image. What are these? Again, for a comparison, these are my RBCs. Again, these are urine microscopic finding. What do you see here? Perfect. That's an WBC, right? They are unstained cells. I won't have staining in a urine microscopy. These are unstained, but you can see inside the cell I am certain irregularity. All these are my WBCs. When I see WBCs in urine, I'm going to give you two possibilities. Only WBC in urine, and I'm having WBCs in urine plus WBC cast. I'll say 1 and 2. Which of these two do you think will be the diagnosis for pyelonephritis? First one or second one? Only WBC, WBC plus cast. Which is pyelonephritis? 1 or 2? Two will be pyelonephritis, right? Perfect. One will be maybe an lower urinary tract infection, urethritis. Could be a bladder problem, right? If you have cast, my kidney is affected, right? Second is obviously pyelonephritis. Great. Fine. What is this? What is this? Bacteria, right? Schistosomiasis is a bit of a stretch. They are tiny cocci, right? You can see the cocci arranged in the form of lines, right? These are tiny cocci. Anything, I am not sure what it is. It's a bacterial colony. I have to do a culture to see what organism it is there. Fine. Okay. Cast will not be beaded. Cast will be perfect. I'll look at the cast. We'll have one more question for cast. We'll definitely look at the cast. Fine. Okay. Now we'll go to a few crystals. Few characteristic crystals. What is this? Where do you see them? Yes, Nirakar. Yes. What is this and where do you see them? The appearance is coffin lid appearance. Coffin lid appearance is seen in calcium oxalate stone, right? It looks like a coffin lid. Coffin lid is seen in calcium oxalate, or coffin lid is seen in which infection? Coffin lid is correct. Calcium oxalate, we see the background one. Calcium oxalate stone, we have an envelope shaped crystals, right? Envelope shape is calcium oxalate. Where do you see coffin lid crystals? We see them in struvite stones. Fine. It's crystals, both are crystals. The shape of the crystal matters. Envelope shaped crystals, maybe something in the background might be a calcium oxide. This coffin lid shaped crystal is in true white stone, right? Great. What is this stone? This is also a crystal. This might be a contaminant, just for us to know there's some contaminant in this shape and it has a name. You must have known this. Some of you must have seen this as well. We call this thorn apple, right? It looks like a thorn apple. Thorn apple shaped crystals, right? This one, very irregular, right? These are seen in your ammonium biurate. Why this becomes important is, this is a very common thing which is seen in my microscopy. Uric acid will be needle shaped crystals. This is called thorn apple. It's in ammonium biurate. When I see ammonium biurate crystals in a urine, I will say it is an older urine. I'm going to repeat the urine microscopy. That's a very common contaminant seen in a routine pathology lab. So an examiner might ask you this question. I have to repeat the test. It's a stored urine, contaminated urine. That's all, fine. What do you think this is? This is what our question had, right? This is your lipid droplets. Okay, this is lipid droplets. The only difference between the lipid droplets and an RBC is the size. I can have normal, bigger, tiny. I can have lots of types, the oil-like appearance or the lipid droplets, that's all. RBC will be uniform size, it will have a various size, right? That's how we can differentiate a lipid droplets and an RBC, fine? Okay, we'll go to the next question. Comment the answer. I want everyone to comment. It's a simple one, but you might make a mistake in this question. Fine. Few seconds, then we'll start the discussion. Answer. Do comment. Some of you might make a mistake here. Vishal, 134 is a very great one, right? Okay, we'll have a look at the question now. See, it's about DIC. If you look at the DIC, most of us will prefer option B because this is one which you have almost many times I've read in DIC, right? But the question is not asking about the diagnosis of DIC. The question is asking which is responsible for bleeding of DIC. Bleeding is due to fibrinogen. Only when fibrinogen reduces, I can say the patient bleeds. The question what is being asked is very, very important. Don't make a mistake here. There are few things in DIC which I want you to remember. Bleeding in a DIC is due to consumption coagulopathy. The one test which directly correlates to bleeding is reduced fibrinogen levels. Because once fibrinogen levels reduces, obviously clot formation will not happen. That correlates to bleeding. What do you think is a sensitive test for DIC? To diagnose, not for bleeding. To diagnose DIC, there's a one sensitive test. What do you think is a sensitive test, most sensitive test for DIC diagnosis? The most sensitive test for me is your FDP. What do you think is a very specific test for DIC diagnosis? Specific test for DIC diagnosis, we have a test called as D-dimer, right? D-dimer is a specific test, fine. FDP is a sensitive test, right? It's okay, trending videos. Hopefully this question comes in exam. The hurt changes to happiness, fine. In exam you will write this correct. If you make mistakes here, that's one reason we want you to know this, fine. See, when Vishal and Abhit, APTT when it's getting elevated, right? I cannot directly say that it will be related to bleeding, because when I say APTT getting elevated, I can have a APTT elevation without clinical manifestation. If my APTT value is given, let's take 70 seconds, it will be correlated to bleeding. I can have 42 seconds also elevated APTT. I can have 500 seconds also elevated APTT. So it's kind of a very random thing. PT also same, right? PT also involved in the clotting cascade. But fibrinogen levels is directly correlating with my bleeding. That's all. Fine. Okay, Saujanya, when I say bleeding, I'm talking about a history. When I'm having an history of bleeding, it is going to be directly correlating to fibrinogen values. When the amount of fibrinogen reduces, automatically what happens is the amount of blood clot formation also will reduce. Once that reduces, my fibrinogen levels will directly correlate to bleeding. PT, APTD, I need the exact values, then I can say it is related to bleeding. FDP is fibrin degradation products. It is clot lysis, will not help me directly to quantify bleeding, fine? The reason for bleeding is consumption coagulopathy, and the most important factor I'm worried about is fibrinogen, okay? This question we already saw, I just want you to comment on that. We'll finish this faster. Right? It's a very simple one. I'm not going to waste time. We saw about PAs. We saw about Alcian blue. PAs is for neutral mucin. It will not stain acid mucin. Mason trichrome we saw, which is for collagen. Where is this used? This is kind of looking like a new thing, right? PTAH. Where is PTAH used? PTAH is used in one very particular thing. It's useful for an striated muscle. It can highlight the muscle striations in a biopsy. That's where PTAH is used. It's phosphotungstenic acid hematoxylin. It's a modification of hematoxylin. It's used for striated muscle, both my skeletal muscle and my cardiac muscle, right? That's just a new information for us, okay? Okay, next question. There are a few easy ones. This is just for us to make no mistakes. This is a simple one. It's a very, very simple one, right? Almost nil metastasis, an exception of a cancer not undergoing metastasis is BCC, right? Trending videos, I know it's a silly mistake. You wanted to answer B, but you typed C. Don't make that in a real exam, fine? It is basal cell carcinoma, local invasion, no metastasis, fine? Okay. Again. Next. Yes, and glioma, correct, Nayatri. Right, a bulky and a friable vegetation, right? And a bulky and a friable vegetation, only thing which I'm going to think about is infective endocarditis. We'll have a quick look about other endocarditis as well, because endocarditis is an important, endocarditis or vegetations is an important MCQ for us, fine? Libman-Sachs endocarditis, where will I see it? Where will you see Libman-Sachs endocarditis? Sure, but I will do it. We'll see them in SLE, right? We're going to see them in lupus or an SLE. Rheumatic carditis, is it infective or non-infective or sterile? Rheumatic carditis, sterile or infective? They are sterile. So if you see superficially, you will think right as an infection because it's streptococcal related. This is an immune mediated damage, so it's a sterile infection. Non-bacterial thrombotic endocarditis. Can you tell one example for NBTE? Non-bacterial thrombotic endocarditis. Any one example? It can be seen in any, the other name is marantic endocarditis. It can be seen in any condition where I am having predisposition to thrombus formation. Can be seen in Aplas syndrome, can be seen in pancreatic cancer, and I have to have predisposition to thrombus formation, that's all. Can be seen in acute promyelocytic leukemia, can be seen in DIC. Any condition I have a predisposition to thrombus formation can cause NBTE, fine? Okay, all of them, right? So anything, any pancreatic cancer or any cancer which predisposed to thrombus formation, I'll have that, fine? I think I had the image of that vegetation somewhere down the road. Just give me a second. Okay. Abid, this is for you. Right. So I can easily know what is the location of all these endocardial lesions just by looking at this image. This is an image from Robbins. If you look at them, my rheumatic carditis, the vegetation will be around the lines of closure. It's called as lines of closure. This is also in the lines of closure. Lines of closure in the sense, the place where two valves meet, that is called as a line of closure, right? Here also I have in the lines of closure. Here also I have in the lines of closure. Infective endocarditis, I can have it anywhere. It's destructive, right? I can have in my chorda tendinae, I can have in my leaflet, everywhere I can have it, right? Okay. I'll share it in my Telegram group, Yogesh. Fine. And when I see a Libman-Sachs endocarditis, the last one is Libman-Sachs endocarditis, second is infective endocarditis here. This I can see on both the surface, which means my atrial surface as well as the ventricular surface, I can see Libman-Sachs endocarditis. Fine. So I'll have both the surface, I'll have Libman-Sachs endocarditis. NBT and the first one is rheumatic heart disease. Both of them are on the lines of closure. My infective endocarditis will damage and it can destroy anything. Okay. I hope that clears your question a bit. Okay, and a few quick and easy MCQs. Yeah. I'm trying to comment on the group name, it's not coming. I don't know why. Okay, it's Pathology by Ranjith AR. That will be the group name. I am not able to comment on it. If I'm able to comment on it, I'll comment. Fine. So the main feature of chemotaxis is it's an unidirectional movement here. Fine. I just want to take a comment on whatever Sanya said. Sanya, it's not about FMGE. Every exam, my question is kind of easy only. It's a perception. I feel something are difficult. I definitely have 60% of the exam questions will be easily achievable. 10% is impossible for everyone. But what gets highlighted is the 10%. My exam is a decent exam, fine. We'll make sure we complete the 60%. Then we are in the competition. Then it will be easy for us to tackle the other things as well. Okay. So this will be the group's name, fine. Okay. Let's go to the next one. Nitrobloom tetrasolium test is used in. Okay, this is a simple one as well. It's a test useful for phagocytosis, right? This is a test useful for phagocytic activity of the cell. And what is the disease I can diagnose using the test? Welcome, Dr. Atif Rose. What is the test? What is the disease I can diagnose? We can diagnose chronic granulomatous disease. Perfect. Okay. I can easily diagnose a case of a chronic granulomatous disease. Not MI, it's chronic granulomatous disease, right? Okay, Niraka, I think you got confused with one more test which is useful for diagnosis of MI. Can anyone pitch in and write the answer? Or you can also answer it. That's also something related to that. What test is useful for the gross diagnosis of MI? Nitroblue tetrasolium test is for my phagocytosis. That's my TTC, right? Triphenyl tetrasolium chloride test, right? It's a tetrasolium, I think, which confused you. Triphenyl tetrasolium chloride test is useful for MI. This is nitroblue tetrasolium, that's triphenyl tetrasolium, fine? I hope it clarifies that, okay? Great. It's just again a simple one. Yeah, correct, Nilakar. Endogenous chemoattractant. C5A is the best chemoattractant. Leukotriene C4. Is it a chemoattractant or not? Leukotriene C4, is that a chemoattractant or not? Leukotriene C4 is not a chemoattractant, right? This is not a chemoattractant. Then which leukotriene is a chemoattractant? Perfect. It's leukotriene B4 is a chemoattractant. C4, D4, E4. What do we call them? This combination of C4, D4 and E4, we have a specific name for them. We call them slow reacting substance of anaphylaxis, right? We call them slow reacting substance of anaphylaxis, which will cause bronchospasm and increases my vascular permeability, right? Okay, great. Okay, next one. Interleukin 8 is also, yes, it's also a chemoattractant. Extrinsic pathway of clotting factor is picked up by my prothrombin time. It's PT. It's a very simple one, right? I'll come to bleeding and clotting time for sure, right? PT tests my extrinsic pathway of coagulation. APTT tests my which pathway? APT is going to test my intrinsic pathway of coagulation, right? All the factors involving the intrinsic pathway. There are few MCQs which keeps repeating in the coagulation profile. The first question, there is one factor which is a coagulation factor which is not involved in the inside the body clot formation. It is used only in the lab. Which factor is not involved in physiological clotting formation, but is definitely will be involved in the lab testing? Which clotting factor is not involved in physiological clot formation? We have factor 12, right? Factor 12 is not involved in the physiological in vivo. It's used in vitro only. In vivo, it is not useful at all. But if factor 12 is gone, my APTT gets elevated, right? That's very important. Factor 5 is important. Factor 12 is not involved in vivo. It's only used in vitro, right? There's no role of factor 12 in vivo, right? This becomes very, very important for me. Why this becomes important for me is it's not involved in clotting inside the body. So if I have a factor 12 deficiency, will the patient have bleeding disorder? Yes or no? Will the patient have bleeding disorder if there's a factor 12 deficiency? No, right? Won't have no. If they won't have bleeding disorder, they'll be mostly asymptomatic. But when I do a factor assay, when I do testings, will APTT be elevated? I'll come to it now. APTT will be elevated, right? That becomes very unique for me here. No bleeding manifestation, right? But elevated APTT. Because it's an intrinsic pathway, the APTT will be elevated, but no bleeding manifestation. That's very unique for factor 12 deficiency, fine? Natrium, it's not involved inside the body for the only reason, inside the body, we don't have this Y-shaped structure. The Y-shaped structure, what we did in physiology and pathology, is for the lab. Inside the body, intrinsic and extrinsic factor both combine with each other and gives an outcome, right? It's not involved because inside the body, endothelial damage is a predominant thing which will involve both of the clotting factors and have a clot formation, fine? Okay. Here's a simple one as well. Great. White infarcts are seen in which of the following except? My question is except, right? Kidney will have white infarct. Spleen undoubtedly will have white infarct. Heart also will have white infarct. The only person which can have a red infarct is liver, right? Liver has dual blood supply. I can have hemorrhagic necrosis, which happens in the liver as well, fine? Liver can have red infarct, right? Tell me other organs where I can see red infarct. Yeah, you guys are correct. Any other organs which can have red infarct apart from liver, which you know? Perfect. One is GIT. GIT can have a red infarct. Anything else? Lungs can have red infarct. Great. There's one more place I want to think about red infarct. Which infarct will have a red infarct? You have an arterial infarct, venous infarct. Which will have red infarct? Arterial or venous? venous will generally have a red infarct. When I don't have a venous infarct, in venous drainage, we call it a torsion. Torsion of testis, torsion of ovary, the outlet gets obstructed. So venous one can have a red lesion, right? Arterial, based on the organ supply, GIT and lungs and liver, I'll have red infarct. Otherwise, I'm going to have a plain one, right? So venous is obstruction, which is torsion, right? Torsion will have the finding, okay? Got it. Well, let's see this. It's an extrapolation of whatever we have seen before. A simple one, right? A D-dimer test, which is going to indirectly tell me I'm going to have an embolism. I'm going to have a clot formation and clot lysis. Only one of this which have a clot lysis, which is very important for me, is my pulmonary embolisms. What is the risk factor for pulmonary embolism? Risk factor for pulmonary embolism? Deep vein thrombosis, right? Anywhere when I have thrombosis, there'll be definitely my D-dimer will get elevated. That's going to be useful, fine. Deep vein thrombosis is one of the important risk factor for pulmonary embolism, right? Great. Okay, next one. This is a simple one, right? I'm sure most of you here will know the exact mutation also. Beta globin, 6-chain glutamic acid to valine. That much amount we know. It's a point mutation. We'll see something related to my sickle cell anemia. What is the other name for sickle cells? We have one more name for sickle cells. What is the name? We call them drepanocytes. Drepano means boat, right? So it's a sickle cell looks like a boat, so I call it a drepanocyte, fine? Okay. So something related to sickle cell anemia. Which type of the sickle cell will cause hemolysis? Reversibly sickled one or irreversibly sickled one? Which is responsible for hemolysis? Reversible sickled or irreversibly sickled? We have two types of sickle cell, reversible and irreversible, which will cause hemolysis. The irreversibly sickled one, right? The irreversible sickle one causes hemolysis. I'll come to it now. Irreversible sickle one causes hemolysis. Perfect. And all other causes of vaso-occlusive crisis is by reversible or irreversible? It's by reversibly sickle cell. Fine. Okay. Vaso-occlusive crisis of your dactylitis, the non-healing ulcer, the priapism, everything is due to reversibly sickled RBC, including your acute chest syndrome. Only hemolysis is due to irreversible sickle RBC. Fine. Now, coming back to a question, when I have your sickle cell disease, do I have good amount of hemoglobin in sickle cell disease? The function is abnormal. The structure is, the quantity is completely fine, right? So it cannot be a nonsense mutation. When it's nonsense mutation, I don't have an end product. It has to be a point mutation only. Fine. Okay, we'll go to it. You want the name for like drepanocytes Neraker? Okay, I'll write the other names. You're going to tell me what is the routine name used. Fine. We'll start with the normal one. Your erythrocyte. Erythrocyte is a normal RBC. Fine. Okay. Fine. What cells are podocytes? Erythrocyte is a normal RBC. Okay, I'll come to it. Please. Podocytes are target cells. Got it. I'll come to it. Fine. Schistiocytes are broken RBCs. Broken cells, right? We'll come to whatever Tawfiq said. What is the other name for bite cell? Bite cell is degmacytes, right? Okay, there's a few other name. We have Burr cells. Degmacyte is a bite cell. Helmet cell and this are different. Burr cell is your echinocyte. Where do you see echinocytes? You see echinocytes in your chronic kidney disease, right? So these are other named thing for my named RBCs, fine. So if any of these names come, you should be able to understand it. We'll go back to the options in Nirakar. Okay, frame shift mutation, nucleotide receptor blockage. See, this is not a mutation. Option C is a way of pathogenesis. And any receptor is going to block, and it's going to have a nucleotide receptor blockage. Ignore that. It's actually a nonsense mutation, not non-sequence. And we'll go about the frame shift mutation. Fine. Yeah, it's seen in G6PD. See, let's assume that I'm having an X gene. Some gene is there where I have a normal nucleotide. So to understand about nonsense mutation, I want you to understand about, I want you to comment on which are the following, which are called as stop codons. I'm sure you must have remembered about stop codons. What comes to your mind when you think about a stop codon? What are stop codons? There are 3 stop codons. What are they? UAG, UGA. AUG is a start codon, right? I want the stop codon. UAG, UGA and UAA are my stop codons, right? Let's say that I'm having an sequence like this. CAG, AGG. This is the normal sequence. I'm having a point mutation. This is my G. Fine. Due to the point mutation, C changes to U. This remains the same. ACC, UAG, AGG. This is the mutated one, right? So when you have this mutated one, will the protein synthesis stop at this point? It stops here, right? It will stop at this point, correct? When it stops exactly at this point, can I say that it is prematurely terminating? Yes. So let's say that this protein was supposed to produce hemoglobin. Will this produce hemoglobin? It will not produce hemoglobin, right? So I call this a decrease in chain length. I call this a nonsense mutation. The protein produced at the end of this mutation will make no sense for me. So I call it a nonsense mutation. If this is beta globin chain, can I say that this causes thalassemia? As beta globin chain, can I say this mutation can cause thalassemia? Yes, it can cause thalassemia, right? If this is beta globin, it can cause thalassemia, right? Beta thalassemia it can cause. Perfect. This is my nonsense mutation. That's my one option. The other option was frame shift mutation. We'll have a look at that as well. Again, I just need a little bit of patience. We can easily understand this. Follow me closely. If you have any doubt anywhere, do comment on what is the doubt. We'll clarify it, fine? Again, this X normal gene is there. Let's take ATC, ATC, ATCG. This is the normal nucleotide. Some random gene. Let's say that here I am having a deletion of these two. Of this, AT gets deleted. When AT gets deleted, after the mutation, what's going to happen to me is it's going to change to same ATC. See, this AT got deleted, so this C is going to come here. Again ATCG, right? How many codons form an amino acid? 1, 2 or 3? It's always 3 codons form an amino acid, right? So here this will read as 1 amino acid, this reads as 1 amino acid, this reads as 1 amino acid, fine? But here 1 amino acid, the second amino acid, can I say that the reading frame is getting changed? It's not only second amino acid. When the second amino acid changes, will the third amino acid also change? Yes, the reading frame changes. Once the reading frame changes, it's called as a frame shift mutation. So the reading in a frame shift mutation, not only that amino acid changes, like in a point mutation, glutamine to valine only, sickle cell anemia. Here, not just that amino acid, this and everything away from that also gets changed. Got it, Nirakar and others? So this I'm going to call it a frame shift mutation. The reading frame changes, so I use the term frame shift mutation. Fine. Okay. I hope it is clear a bit, or I confused you more. Okay, great. Fine. We'll go to the next one. Where is the question? It's a factual based question. Let's see if you're able to answer this. Yes, Amir. Prader-Willi syndrome, which of the following is increased? Perfect. It's ghrelin, right? Because of ghrelin, yes, like Ranjith said, that it is one of the syndromes with obesity, childhood obesity, because not only obesity, hyperphagia and obesity, right? Because of ghrelin, patients will have hyperphagia. Along with that, there'll be obesity. Fine. That happens in your Prader-Willi syndrome. Yeah, more appetite, eats more, and the kid becomes bigger. Okay. Next one. Yeah, hypotonia as well. Yeah. Great. Karyotyping is obviously done for chromosomal disorder. Ignore this. Don't come into it. We might see linkage disorder sometime down the road because it's an entirely separate topic. If you are preparing for USMLE, linkage disorders are required. Indian exam, we'll try to ignore that, right? So chromosomal disorder, I'm going to give you two options. Tell me which is better, fish or karyotyping. Which is better? Fish is better than karyotyping, right? Perfect. This came in a question once, so we know that. But I have to understand the nuances of fish. I'm going to change the question a little bit and I'm going to ask you. A patient comes with a bad obstetric history. Okay? Patient has a bad obstetric history and I'm having an abortus. And bad obstetric history, a recurrent abortion in the first trimester. When first trimester abortion and apply is ruled out, can I say that first trimester abortion? I'll come to it in a minute. When I say first trimester abortion, can I easily say that one of the commonest cause apart from apply is chromosomal disorders? Yes. So in this condition, which is better, fish or karyotyping? Which is better, fish or karyotyping? In this condition, I want you to do karyotyping, not fish, right? Perfect. The simple reason is I can do karyotype fish only when I know what I'm looking for. For example, I'm looking for Philadelphia chromosome 922. I can do fish. They are much more specific. It's very easy to do and I can have the result crystal clear. Amir, your answer here is it's much more specific. Karyotyping has many of the complications. One, I need a dividing cell. Fish I can do in a resting cell. There's more resources required for karyotyping. Fish is much easier to do and much more accurate, so I prefer fish. But here, I don't know what I'm looking for. Do not know what abnormality will be present. So if I'm not sure of what abnormality is present, I prefer karyotyping. I can't do a fish in this patient, fine? Both are for me chromosomal abnormalities only. But if I know what I'm looking for, fish is better. If I don't know what I'm looking for, karyotyping is better. Fine. Okay. Go to the next question. I was just looking for someone who will answer option A, right? Good. Sure sign of malignancy, it's metastasis. One of the commonest problem for mistakes is you don't read all 4 options. You look at first option, it looks correct, you tick and come, right? Don't do that. Please read all 4 options. Sure sign of malignancy is metastasis. Robbins mentions 3 things as hallmark. I really don't know what to choose as hallmark. I am going to leave it to you guys, fine. Anaplasia is hallmark of malignancy. Invasion is hallmark of malignancy. Metastasis is hallmark of malignancy. I hope the examiner will be sane enough to give not all 3 options in the same question. If it is the same question, I really don't know what to choose. Anything can be the answer. All 3, when I see them, I am going to say it's cancer only. It is malignancy. All 3 will not be in the same option. If it is there, it should be a multiple option question. Right? Okay. A simple one again. It's a simple one. Please don't make mistakes in this. The starting point of any cell cycle is G0. The ending point is mitosis. So the only possibility is these 2, right? These 2 are not possibilities at all, right? C and D can never be the answer. So G0, G1, S, G2 and M. So the correct answer is option A, right? Okay. It's completely fine, right? We will know what all we are bad at. We hopefully will, if the same question comes in the exam, Abid, you will not make a mistake. See, these sessions are make you understand where you are lacking, and definitely you will make sure you will complete it, right? Okay. So I'm just going to ask some questions in relation to cell cycle. When I have something called as a stable cell, first tell me examples of stable cell. Tell me at least one example of stable cell. One example of stable cell. One example. Stable cell, any parenchymal cell. Perfect. Hepatocyte is a stable cell. Neuron is not a stable cell, right? Neuron is a permanent cell. Hepatocyte, pancreas parenchyma, kidney parenchyma, every parenchymal cell are stable cell only, right? Okay. So stable cell, first year answer your question, Amit. So stable cell will stay in which phase of cell cycle? In which phase of cell cycle do we have stable cell? Okay. Stable cell always will remain in G0 phase. Fine. It will remain in the G0 phase of cell cycle. The most radiosensitive is G2M, then G2M or M, whatever it is. Radio resistant is late S phase. Late S phase is radio resistant. Fine. It will be in G0 phase. Okay. G0 phase is where almost every stable cell will be. When I say a labile cell, give me an example for labile cell. Labile cell are constantly dividing cells, right? Your epithelium, almost every epithelium is made labile cell. So a labile cell will be inside cell cycle. I cannot say what phase they are in. It can be G1, S or G2 or M based on the division. Every epithelium, hematopoietic stem cell, everything is a labile cell. It will be in either of these. Fine. They are constantly dividing. It will be here. Fibroblast amer is in stable cell. Fine. It will not be a labile cell. Okay. There are a few questions related to that. Next one. Okay, want everyone to comment here. Okay, the reason for me want to comment is there's 2 conflicting answers in the poll, right? So I have B as well as A. I'm great that none of you answered C and D, right? This is definitely not there. It's not going to help me in the recurrence of tumor or in the screening of breast cancer. Perfect. So HER2/neu is not useful for diagnosis of breast cancer. I don't want for diagnosis. I don't want this, right? It's for predicting the therapeutic response. Like Amish said that I can give trastuzumab if it is HER2 positive, right? HER2 if it is positive, I can give Herceptin or trastuzumab. It's a prognostic marker. It is not useful for diagnosis. Can I say that ER, PR, HER2 all these three are prognostic markers? Do I need ER, PR for diagnosis of a breast cancer? I don't want that, right? Both ER, PR and HER2 all these three are prognostic markers only. I don't want it for diagnosis, right? All of them are prognostic markers. My ER, PR, HER2 all are prognostic markers. I don't want anything for diagnosis. So how I'm going to use it for prognosis? It's just based on differentiation, that's all. Yeah, I can give hormonal therapy, tamoxifen if they are hormonally positive, ER, PR positive. Let's say that I'm having a breast cancer or a normal breast tissue. Can I say a normal breast tissue will be ER, PR positive? A normal breast tissue will be ER positive, PR positive, for sure, right? The same way, when I take a breast cancer, I'm writing BRCA for breast cancer. It's not BRCA mutation, it's just a breast cancer. Okay, it's normal, right? So when I take a breast cancer, if that is ER positive, PR positive, it is resembling my normal breast parenchyma. A breast cancer which is ER, PR positive, it's resembling my normal breast parenchyma. So can I say that they are well differentiated? Same like my normal breast, they are well differentiated. So my prognosis is good or bad? It should have a good prognosis. In other words, I have a cancer, the luminal A. I call them a luminal A, right? I have a cancer which is ER negative, PR negative, HER2 negative, triple negative breast cancer, which is not resembling like my breast parenchyma at all. They have the worst prognosis. Okay, so triple negative breast cancer, which will have the worst prognosis. Again, all of them are useful for prognostication. I am not going to use any of these markers for diagnosis. I do use IHCs for diagnosis. Here they are useful for prognosis. Fine. Okay. Next one. I'm sure you know the answer of this as well. Great, right? RET proto-oncogene is associated with which malignancy? You wrote it's medullary carcinoma thyroid. Will pheochromocytoma have that? Is that possible for a pheochromocytoma to have red proto-oncogene? See, this is correct. I'm just asking you, is it possible or not? Yes, no. Also, right? So red proto-oncogene mutation, can it cause your MEN syndromes? Red proto-oncogene will cause MEN syndrome. Yes, it will cause both MEN 2A and 2B, which has to do with red. So MEN 2A and 2B, one of the component is pheochromocytoma. Yes or no? Will be there, right? So both MEN 2A and 2B will have pheochromocytoma. So still, why most of you wrote medullary carcinoma thyroid as an answer is only when it is syndromic, only when it is associated with MEN syndrome, pheochromocytoma can have red mutation. But medullary carcinoma thyroid, whether it is red sporadic or syndromic, I can have a red mutation, right? So most when you have a question, it's always choose the best answer. It's not the correct answer. For a best answer, I'm going to prefer a medullary carcinoma thyroid over a pheochromocytoma. But undoubtedly, both of them can be associated with red mutations. Fine. If you have multiple option questions, please choose both of them. Fine. Okay. One more. Good. It's a simple one, right? Paragonimus westermani is a lung fluke, if I remember it correctly. PD-worm is not going to cause any cancer. Cholera definitely doesn't cause cancer. Schistosomiasis, like you guys said, it will cause bladder cancer, right? Okay. Yeah, very interesting story about schistosomiasis. We will maybe end the session with that story, or maybe a couple of few more MCQs as well. See, schistosomiasis was diagnosed by Napoleon, right? I like the story a lot. So Napoleon went to a tribe in Africa where he saw men were menstruating. They had a custom where men were menstruating. Okay. So when he came to France and said that I saw in Africa a tribe where men were menstruating, I don't know what is the reason. So when doctor went there and saw that, they had a custom built around schistosomiasis. Schistosomiasis, when it causes bladder infection, it will cause intermittent hematuria. So that was celebrated as men menstruating in that community. Not just that, they also created something around that. So what they did was, if a kid is not able to have hematuria, or in other words not able to menstruate, the older grandfathers in that community used to pee in the pool and made the kids dance in the pool, and then they miraculously caused menstruation. How does schistosomiasis invade my body? The larva via skin penetration, right? The larva via skin penetration goes into my body, gets colonized. So when the kids danced in the pool of urine, the larva got inside and it had schistosomiasis and they were celebrating it as men menstruation, right? So why I wanted to say this is, if we always think that we are stupid. When I don't know an answer for an MCQ, most of the students say that, okay, I don't know anything, I'm a stupid person. This is stupidity, right? People were celebrating schistosomiasis as men menstruating. We have come a long way across it, right? So not knowing an MCQ is nothing, right? It's amazing. We have amazing stories. I'll tell you one more instance where we are stupid. Have you seen in older movies, most of the judges will have big hair? Have you seen that? Many judges in the old movies will have big hair. You must have seen that, right? So that is also a stupidity. Yes, Anshri, right? So what happened is, there was a judge in England. So the England judge who had huge hair, and he was very good in diagnosing things, giving a very good judgment. So what they did was, they thought that the increased hair gave good judgment capacity to the person. So all big people started growing hair, including Newton. The problem was, the judge had increased hair growth because he was suffering from syphilis. One of the side effects of syphilis was hypertrichosis. So hypertrichosis gave the big hair, not the hair is linked to the brain, right? So we were so stupid in the 17th-18th century. We thought that hair is important for the intellectuality, not something inside the hair, right? So we were at many places. Medical science will tell you I was stupid multiple times. So not knowing an MCQ is not being stupid. At the end of the thing, the take home message is, even if you don't know something, it's completely fine. Do answer this question and we'll call it off a day with the help of this question. Fine. There are multiple interesting stories. Malinga should be the most intellectual person. Yeah, true. Right? Why choriocarcinoma? Alpha fetoprotein? Okay. For who answered choriocarcinoma? What is the marker for choriocarcinoma? Beta HCG or alpha fetoprotein? This is beta HCG, right? It's beta HCG, not an alpha fetoprotein. Alpha fetoprotein is a primary marker for my hepatocellular carcinoma. Fine. Okay. So alpha fetoprotein is a marker for hepatocellular carcinoma. Seminoma, I actually don't have any specific marker. LDH will be elevated in seminoma because LDH tells me the tumor load. It doesn't, it's not specific for seminoma. Like Shastri said that for alpha fetoprotein is also seen in one more testicular and ovarian tumor called as an yolk sac tumor. Okay, it will be elevated in yolk sac tumor as well. I don't have any tumor marker for my renal cell carcinoma. Alpha fetoprotein for HCG and yolk sac tumor. Seminoma can also have beta HCG elevation, only when it has sensation trophoblast like areas. Okay, otherwise it will not have beta HCG elevation. Fine. Okay. Okay, that's for today's question. So we had discussed, I think, more than 30-40 MCQs. Okay, we took 1.5 hours, but I think it will be worthwhile, right? So if you are joined in middle, you can go back and have a quick look again at them again. Fine. Okay. Yeah. So thank you for your time. If you have any doubts, you can contact me in the Telegram group or in Instagram, or you can download the Unacademy app. You can follow, my name is Ranjith. You can follow me and you can send me a message inside the app as well. Whenever I get time, I'll definitely give you the answer. Yes, Shashti. It's secreted by sensation trophoblast. Okay. Thank you for your time, guys. See you soon. Till then, bye. I did reply. It'll come back. It'll come soon. Okay. See you. Bye.